Give me just a second. So Dr. Nikki, is it Clague-Baker?
Yeah,
Is that
Clague-Baker,
correct?
yeah.
Clague-Baker, okay. She has been qualified as a physiotherapist for 31 years. She has worked clinically in Manchester, is it Cardiff, Philadelphia? Oh, I see that now, yeah, and Leicester. For the last 16 years, she has taught neurological physiotherapy and research at Coventry University, University of Leicester, and University of Liverpool. She was funded by the Stroke Association to complete her PhD on the topic of cardiovascular fitness in people post-stroke. She has published and presented this work nationally and internationally. In 2021, she was funded by the ME Association to invest the physiological effects of everyday activity for people with myalgic encephalomyelitis, known to people with ME. Also in 2021, she was funded by the University of Liverpool to explore the use of heart rate monitoring in people with ME using an international survey approach. She is now running a mixed method feasibility study exploring the use of heart rate monitoring for people with ME and long COVID. In addition, she has conducted a survey of and is planning a randomized controlled trial exploring the use of transcutaneous vagus nerve stimulation for people with ME. Her ongoing research interests relate to neurological physiotherapy, in particular ME, long COVID and stroke, and in the areas of fatigue management, exercise-based rehabilitation, mental health, and healthy lifestyles. She continues to work clinically, seeing private neurological patients. So thank you, Nikki, very much for being here.
That was a long one, wasn't it? No problem. Can you see my screen?
Yes.
Yeah,
yes, we
lovely.
can.
Okay. So I was going to talk about the two different presentations that I provided at the IA-CFS ME conference. We'll see how much time we have. But this first one, as Melinda said, was funded by the ME Association, and we were particularly interested in what physiological measures we could test, if you like, with people with ME in their own homes, rather than bringing them to clinics and making it quite challenging for people with ME, particularly severe ME, to come to us to do testing. So this was a feasibility of investigating oxygen consumption, heart rate variability, blood pressure, lactic acid levels, and activity levels of people with myalgic encephalomyelitis during normal daily activities. So I sort of did the data collection, but supported by Professor Helen Dawes at the university. At the time, she was at Oxford Brookes University. She's now at the University of Exeter. Professor Sarah Tyson, who is actually semi-retired, but she's based at the University of Manchester. Dr. Michelle Ball, who's one of four of us who are physios for ME. So Karen Leslie, Nat Hilliard, and myself as well. So see if these slides will move on. I wanted to include these first two slides because the whole reason that I'm doing research into myalgic encephalomyelitis is my best friend. We grew up together, and we both went to university in different parts of the UK. And I carried on, and she didn't. She had a virus when she was at the university, and so for the last 30 odd years she has struggled with myalgic encephalomyelitis. Excuse me. I probably shouldn't put those pictures on because it always makes me feel quite emotional. Anyway, the background into, as you might be aware, and I'm sure you are aware, that people with ME have abnormally low maximum oxygen consumption when measured with a cardiopulmonary exercise test, and they reach anaerobic thresholds quicker than healthy controls. And some studies have found that people with ME also have greater levels of lactic acid when doing these tests. And just a reminder of what a cardiopulmonary exercise test is. You either sit on a bike or going on a treadmill, and you have a mask on your face, and it records your oxygen levels, oxygen consumption. So the level of oxygen coming in and the level of oxygen breathed out. It also measures the amount of carbon dioxide produced. And usually you have ECG on to check your heart activity. You have a blood pressure monitor, checking obviously your blood pressure every couple of minutes. And it the speed of the speed maintains the same, but the resistance usually increases. So over a set period of time, you're pushing that person to do more and more activity. And the idea is that you are aiming to reach a limit of maximum activity and maximum exertion. And that's the point where the amount of oxygen consumed is actually less than the amount of carbon dioxide produced. It obviously relies on healthy lungs to take in the oxygen and carbon dioxide to breathe out carbon dioxide. It relies on healthy heart and circulatory system to conduct that oxygen and carbon dioxide around the body. And it obviously relies on the muscles and the mitochondria to take up that oxygen and to remove the carbon dioxide. So if there's anything wrong in any of those systems, then there could be an impact on the oxygen consumption and carbon dioxide produced. So as I say, the idea is obviously you're pushing that person to their max or their peak, to the point where the oxygen consumed is less than the carbon dioxide produced. And this is called the ventilatory anaerobic threshold. And it indicates where we switch from aerobic to anaerobic metabolism. And in theory, it's where there is more lactic acid production. There is some debate about whether we call that the lactic acid threshold as well. So you might be aware that with people with ME, they've done a number of different studies now looking at a two-day CPET. So they do the CPET on one day, have a 24-hour break, and then they repeat the CPET on the second day. And this is one study, but there are a number of studies now that have been looking at this. Lian et al. 2019. And often what is found on the second test, the ME participants have a significantly lower VO2 peak and a lower anaerobic threshold compared to the controls, and usually significantly dropped on that second day. And with Lien, they also found that there was higher levels of lactic acid production on that second test as well. However, it's unclear. A lot of the resistance, certainly in the UK, is that medics say, well, that's people pushing themselves to the max, but people with ME, they're very rarely pushing themselves to the max. So what's the problem? So the argument is that, you know, what happens during everyday activities, and is this happening actually when people are just doing normal everyday activity? And certainly a lot of people with ME are saying that they feel that they're reaching their max during everyday activity, but there hasn't been many studies that have looked at that. So this is one of the reasons we wanted to see what was happening during everyday activity. Another reason was to think actually the CPET tests can be potentially harmful for some people. And obviously it's much more common for CPET tests to be conducted in the US, but in the UK it's very rare that people with ME are tested on a 2-day CPET test. And obviously, well, not obviously, but in the IAC CFS ME conference this year, I was interested to hear that Moore et al., and I don't think it's been published yet, identified that up to 7% of people with ME who undertook the CPET test took up to 10 weeks to recover, and actually 1% didn't recover after a year. So even that 1%, I think, is important to consider that, you know, whether the CPET test is the best option for them if they're not going to recover outside of a year. And certainly, as I say, outside of the US, there is a lack of CPET testing for ME CFS patients, and we just wondered if there's an alternative to that, so that isn't as harmful, and perhaps, you know, doing these tests in everyday activities might offer an alternative for people with ME CFS. So the aim of the study was to investigate the feasibility of physiological measurements of people with ME in their own homes during everyday activities. So obviously feasibility of any study is based on the ability to recruit into the study, the acceptability of the procedure, the acceptability of the outcomes, and the responsiveness of the outcome measures. So this is what we looked at. So the method was we aimed to recruit people who met the ICC criteria, and we only had a small amount of funding, so we really we would have struggled to get the same number of healthy comparators. So we only managed to get a small number of healthy comparators. But it was more about feasibility rather than the outcomes, although that has been interesting to see as well. So what I did was travel to people's houses and got there first thing in the morning before they got up, and we asked them not to eat anything. They could drink water. And then we were obviously consented them, and then we put this portable metabolic system, so they wore the mask. I fitted them with a heart rate variability monitor. You can see on Karen here, this is the heart rate variability monitor, which fits like this. We took their blood pressure and their heart rate and their oxygen levels using a pulse oximeter. And finally, lactic acid levels were taken with this lactic acid monitor. And we asked them to lie for 5 minutes, and I took blood pressure, heart rate, oxygen levels before and after lying down for 5 minutes, and then in sitting for 5 minutes, before and after sitting for 5 minutes, then standing for 5 minutes before and after, although not everyone could manage the standing. And then we went into the bathroom and simulated 5 minutes of bathroom activity. If they were able to, we then went downstairs, and each time I was taking blood pressure and heart rate before each activity. Sorry, before and after each activity. If they could manage it, we would do 5 minutes of kitchen activity. And then if they could manage it again, we'd go back up the stairs and then finish off with a very simple cognitive test. Now, I did try and find a standardized cognitive test that we could use, but we only wanted one that was really quite quick and easy to do. And so I really struggled to find one. So what we did was use a simple one that we tend to use with our stroke population. So counting back from 100 to 0, taking away 7 each time. And then I did a very simple, well, it wasn't so simple actually, mental maths test, which was not validated. So it was interesting. It took about 5 minutes to do that cognitive test at the end. So all the way through, we were monitoring their oxygen consumption, VO2 production, And as I say, heart rate variability and blood pressure, oxygen levels and pulse and lactic acid at the beginning and the end of these activities. So after that, they continue to wear the heart rate variability monitor for up to 6 additional days. And we asked them to record their blood pressure in the mornings and the heart rate and oxygen saturations and lactic acid in the mornings and in the evenings. And if they had any post-exertional malaise, to do the same measurements as well. We asked them to measure with a diary their activity and their post-exertional malaise over those 6 days. And we recorded their fatigue severity scale at the beginning and the end of the week. And we also, when we went back to pick everything up, we asked them to just give us a little bit of feedback about how easy or hard it was to do all of this data collection from an acceptability perspective. So as I say, this portable metabolic chamber measures oxygen consumption, carbon dioxide production, minute ventilation, which is your respiratory rate times your tidal volume. It measures your increase in ventilation due to the VCO2. It also measures that respiratory exchange ratio. So it gives us an idea when they're switching from aerobic to anaerobic metabolism, because once they go over 1 with this respiratory exchange ratio, that in theory is that lactic acid threshold, and they're switching to anaerobic metabolism. And we also measured breath frequency or respiratory rate. Heart rate variability, the monitor on their chest was measuring the variation in the time interval between consecutive heartbeats in milliseconds. In theory, a healthy body should have a good variability or a constant variability. It shouldn't be metronomic. And in theory, this is a non-invasive marker of autonomic nervous system activity. So an increased heart rate variability, in theory, the better the autonomic nervous system, or the better the balance between sympathetic and parasympathetic activity. Lactic acid is produced during anaerobic metabolism, and an increased lactate is an excess of production or a shortage of usage or clearance of lactate. And that could be due to an increase in exercise intensity where the energy required cannot be supplied mainly by means of aerobic energy formation, or it could be a deficit of oxygen because there's circulatory problems leading to tissue hypoxia, or it could be a limitation of enzyme activity. So there's an increase in circulating catecholamines, which leads to anaerobic glycolysis. So the level of lactic acid would give us an indication that there's an abnormality, but we might not know exactly why they're having that abnormality. Is it due to a deficit of oxygen, problems with enzymes, and so on? We can only say that there's a problem because there's an increase in lactic acid. So we recruited 17 people with ME and 5 healthy participants. 71% were female, mean age was 45. The mean duration of having ME was 15.3 years. 2 had mild ME, 10 had moderate, and 5 had severe ME. So in terms of feasibility perspective, the recruitment was successful. We recruited 20 people online in 4 hours. It was a very quick process, and actually we managed to recruit over 70 people in 24 hours. So we stopped recruitment after 24 hours. Procedure, all participants found the procedure acceptable and were able to complete some of the activities. And obviously the more severe the participants, the more difficult they found certain activities. And only 13 managed to stand still for 5 minutes, and only 14 managed all of the activities. Outcome measures, the measures were acceptable to all, and they did identify changes in people with ME. One person with severe ME struggled to take ongoing measurements due to cognitive difficulties because she lived on her own, and everyone struggled to take measurements when they were in pen. So this is something to bear in mind if we were to do this again. So the results from the metabolic chamber, so the production of carbon dioxide was consistently higher in people with ME, and the RER, that respiratory exchange ratio, was higher than healthy participants, and going over 1, particularly during cognitive activity, bathroom and stair activity. So it was really interesting. The very first participant we had was a young guy, and he was doing fine, doing everyday activity, bathroom, kitchen, went up a little bit with the kitchen, but as soon as we hit the cognitive activity, his RER just went up and up and up and up, indicating definitely something happening anaerobically, switching to anaerobic metabolism, and it stayed up there as we did that 5 minutes of challenge. So, you know, it was a real interesting, and we were, you know, there was 2 of us doing it at the time, and we both just looked at each other and just sort of pointed at the, like, what's happening? And we saw this not with everybody, but certainly, and I'd have to look at my numbers now, but there was a good 5 or 6 people where that RER just really went extremely high. Another interesting, which I hadn't anticipated at all, there was 2 people had RER in supine lying over 1, indicating that they were in anaerobic metabolism in supine lying. But when they sat up and when they stood up, it became more normalized. So I do wonder whether that's indicating some structural abnormality or problems with the lungs in that position. So yeah, it was quite an eye-opener, that. And one of them said that they always wake up in the morning feeling very groggy and very lots of headaches and things. And it's not surprising if that system is working and producing so much carbon dioxide. Heart rate variability. So the system that we use, the first beat system, converts the sympathetic parasympathetic balance, if you like, into the percentage recovery and percentage physiological stress. And we found for 7 people with ME, they had no recovery, day or night. They were constantly in high levels of physiological stress in their autonomic nervous system. And all people with ME had a higher level of physiological stress and lower levels of recovery in their autonomic nervous system compared to healthy participants. Lactic acid wise, bearing in mind that all people with ME had very little activity, all of them had higher levels of lactic acid during the week of testing. And obviously that didn't reflect how much activity they were doing. And there was 2 people in particular that had extreme high levels of lactic acid, and they had quite significant pain, which did seem to correlate with that level of very high lactic acid. When we looked at heart rate and blood pressure, all people with ME had constantly raised heart rates, which has been shown in other research before now. 6 people had diagnoses of POTS, and 14 had orthostatic intolerances when we tested them. So some, I think, were undiagnosed POTS patients. One person had a significant rise in blood pressure on standing, which was quite a really unusual response. And actually I wrote to the GP for all of the participants, but this particular lady she definitely had some very strange dysautonomic responses. And I said to the GP, after 30 years of working as a physio, I'd never seen such an extreme response in blood pressure in standing. She couldn't manage 10 minutes of standing, and her blood pressure kept significantly rising. And I actually got her into half lying because I was worried about her. And her blood pressure continued to rise in half lying, and it took about 20 minutes for that blood pressure to stabilize. 6 people had a significant drop in blood pressure on standing. So, and this is the thing for me, is that there's just so much variety, you know, in this group of 17 people. There probably wasn't, well, there wasn't, you know, everyone had slightly different presentations. And I think for me was such an eye-opener in terms of the importance of individualized assessments and individualized treatments, because there obviously is such a significant difference between everybody's responses. But they've all, you know, got a diagnosis of ME, but they all have different problems, and you know, it's important to pull those out. And fatigue questionnaires. So we used one fatigue questionnaire, which was originally designed for stroke patients, but you know, it was a bit of a blunt measure for fatigue, but it certainly indicated over that 5 days that there wasn't a significant major effect on fatigue as a result of the testing. So we did some, as I say, so we had some qualitative responses, and some of the comments: "It's been a real privilege to be part of the study. Thank you for allowing me to participate, especially at severe level. I'm so excited about this evidence. I know I'll send it to many people, starting with my cardiologist. Thank you again. I feel extremely fortunate to have been involved in your study." So as I said, I did send all of their individual results to them so that they could use them in what way they could to support speaking to their GPs, maybe getting referrals to cardiologists and so on. I had a couple of issues with the heart rate monitor. The stickers don't seem to be that sticky and fell off a couple of times. Another time the bottom clip came off. Otherwise, everything else has been great. So there's just a few teething problems with some of the testing. So in conclusion, physiological measurement during everyday activity is feasible for people with ME with mild to severe disability. Activities need to be adapted for different severities of ME to identify abnormalities and prevent harm. So for the very mild end, they were quite keen to push themselves that little bit more to identify where their problems lay. So, you know, it's possible that they could have managed a CPET test and that would have been absolutely fine for them. So I think this is something to consider as well. It's possible to recruit and the procedure is acceptable. The outcome measures identified abnormal physiological changes, and further research is needed to develop diagnostic and possible treatment protocols. So, yeah, we'd like to see if this is something. We see it as a sort of clinical tool, I think, to allow us to identify issues and to focus treatments potentially, because, as I say, it did identify a number of people with dysautonomias that hadn't been picked up, and you know, with these high levels of lactate and so on. I think there's things that can be done for these people that haven't been identified so far. References. And I just wanted to say thank you to the ME Association for funding it and all the people with ME who took part. It was quite an eye-opener.
I think it's just absolutely fascinating. I know it was a lot of work, but and the basis of it is really so simple. I mean, everything other than the gas exchange device is really something that most PT clinics have read available, and blown away by, how practical it all.
Yeah.
And then I don't remember, I mean, partly it's probably my cognitive limitations, but you mentioning some of the things that you mentioned about like the structural stuff and all, that's just crazy that that type of, maybe it isn't that, but that you're picking up on these things that, what simple ways to screen for things that could make powerful, decision making determinants for plans of care and cost again.
No, I agree. And I think the other thing to say is the importance of going to people's homes to do it. And I think we flagged that up at the conference actually, that so for this one lady who had quite severe blood pressure issues, she'd been to a doctor a number of times and said, I've got problems, and every time they'd take the blood pressure and everything's fine. She'd even had a tilt table test and it hadn't flagged anything up. Partly she thinks because by the time she gets there, her blood pressure is always so high that it's not actually showing that significant change because she's already in a state of stress. Whereas by going in first thing in the morning and actually this is what I'm normally like, and then doing that standing test showed quite significantly what happens normally for her, that this is not normal. And actually we're just doing another study now, looking at heart rate monitoring, and I did some baseline measures for somebody else, and she was in a state of PEM because she'd done other things prior to me doing that test, so she was in bed. But I did the same sit. Well, I didn't do the sitting, and we went from lying to standing, and she had significant autonomic changes. And again, she said she'd gone to a GP about it, and the GP just said, well, take your own blood pressure, see what happens. And of course she hasn't got the energy to do that. She hasn't got the capacity to do that on her own. So it was just, and I said, well, once we've finished the study and I've got more data, we'll definitely get that to the GP and say, look, this is not normal, this is not right. And this is what I'm saying, that actually in the UK, we're not as good as the US at picking up the autonomic changes at all.
Well, this kind of sounds obvious, but and I know that you guys are working on getting this published, but it would be really a curiosity to me to see a breakdown of the cost of the devices that you use.
So the lactic acid monitors, they're about £400 each. The most expensive thing is the actual strips. I can't remember how much they are now, but if you were to do that on an ongoing basis, you would need I think it's probably per box of strips, I think it was about 30. I'd have to check now. But it's not insignificant, the amount, but that's in your system it'd be fine, I think, because you can obviously perhaps get that. This is something we've written in the subsequent article, actually, that it's like a diabetic, taking blood sugars, and that's funded, that they've got a little machine and they've got, strips, and that's funded, and that's fine. So why can't we fund, if people have got obvious levels of lactic acid problems, then let's measure it and let's do it on a regular basis and see what we can do to sort of manage that, So I think, there are certain things clinically that, so the lactic acid monitor is about £400. Obviously, pulse ox is really cheap. Blood pressure is really cheap. The heart rate variability monitor is about £300, but it does require, you have to either pay, there's a new system there that you can pay for the app, or you pay for 6 months of software use with that, so you can upload data and so on and analyze the data. But you know, it's a good, we've used this twice now, this system, and it works really well. And I know the reason why we started using it was because one of Physios for ME works in a long COVID clinic, and they had started using these devices, and had been recommended by a physio who works a lot with athletes and uses these systems, so that the athletes in the mornings can say, okay, this is the state of my autonomic nervous system. Either I can train really hard, or I need to back off a little bit because my body can't cope with it today. So yeah, he uses those systems for high level athletes. And then the portable metabolic chamber, unfortunately, is very expensive. So that's in the UK, pounds wise, it's about £30,000. But, you know, I would say it's a good investment for any, you know, that's what CPET tests are based on. They use this portable metabolic system. And, you know, but you don't have to necessarily push somebody to their max to do it. So, you know, I think, yeah, I think it, and also, you know, if you've got a person who's perhaps more mild, you can do this sort of everyday test first and go, actually, you know, and they're keen to do more, and they think, and they don't have a massive response after doing something, you could perhaps rank up the challenge. And the other thing, actually, I was speaking to somebody else at the long COVID conference, actually long COVID physio conference, and they'd said that they'd done a CPET test but stopped straight away as soon as they hit their anaerobic threshold, and so they had less, but they knew what their heart rate was at that level, so that they couldn't set their heart rate monitor to work. So so it's a little bit more accurate. So you know, that's another thing, I think, that using this portable metabolic chamber, you could, you know, work out somebody's anaerobic threshold for certain activities. So if we know that they're hitting it when they do their, which was quite common, doing their bathroom activity, then you'd sort of perhaps measure what activity is causing a problem, and you back off that. I mean, sometimes you get that immediate response, don't you? But often it's delayed. So if you have that activity monitored, and you can then say, actually, yeah, let's not do this so much, but you're okay with this activity potentially. Yeah.
I had a 1-day CPET done about 11 years ago. My ME specialist at the time would do 1 day. I reached my anaerobic threshold in 30 seconds. So I've been monitoring, you know, doing, we call it heart rate biofeedback pacing is what our group calls it, because we want people too to look at it like a diabetic, you know, checks their blood sugar, and this is a way just to check in with yourself. And so I've been doing heart rate biofeedback pacing for years and years. And even though I'm better since my craniocervical instability surgery, I still pace. I think that's one of the reasons I've done as well as I have, because I still pace myself. But one of the newer things that let me back up a minute. I know that, you know, Workwell did a study, and that they found that people with ME tend to have chronotropic intolerance, you know, which means, you know, that for our age, this and that, you know, we don't meet the standards that have been created for age and activity. So what I don't know a lot about, honestly, I don't know anything about, other than I'm starting to hear the term and I'm listening to you, is heart rate variability, you know, and I'm wondering if, I know the people in the below the measurement Facebook group, I know they say that they can actually predict a crash based on heart rate variability. But I mean, one question is, how accurate is that if we know that there's chronotropic intolerance, and that is it being, like you said, the guy was doing it with high level athletes, you know, so the standards that are being used, can we correctly extrapolate what that means for a person with ME? But also, I'm very interested in learning more about heart rate variability. Is what
Yeah.
you said, the type of device that you used, is that the same that are on a lot of wearable devices? Like,
So, yeah.
my watch has a heart rate variability
Yeah.
thing on it.
Is it a Garmin you've got there, or is it?
No, mine is an actual Apple Watch that I use.
Yeah.
So I never
Obviously,
pay attention to the heart rate variability.
no. Well, I mean, obviously, the other presentation I did was about the survey that we did with heart rate monitors, and not everyone uses heart rate variability, like you say, and most people are using, you know, the limits and alarms to stop going over a certain level. I think partly because it was mainly European and English or UK participants in the survey, that they had less knowledge and they had no CPET tests to put their limits at. So it was a real variety of where they set their limits and so on. But there were some people that did use heart rate variability, and I did do some follow-up interviews with some of them, and they were saying that what they tend to do is use their device, if it does show heart rate variability, that they lie in the morning and just get a heart rate variability measure, and then it gives them an idea of where their autonomic nervous system is on that day. And like I said, with the athletes, if it's too low, they'll go, actually, I'm not going to do as much as I planned to do today, because that's not going to be very helpful. And some people track it over time, and then they see what's normal for them. And then if it's pretty low for them, then they are very mindful about. But in terms of the accuracy, there hasn't been anything done in terms of, you know, people with ME or people with long COVID or people with disability, and how good heart rate variability is measured on a watch compared to something that sits around the heart and actually has a little bit more validity. And so, interestingly, for the survey for the study that we're doing at the minute, I am hoping we can get some validity data on this, actually, because we're going to get some people wearing the heart rate variability and wearing the heart rate monitors at the same time. So, but it's only with a Garmin, and also a new device that's been developed by Visible, that's using an app that is designed for people with. But at the minute they haven't got their heart rate variability set up yet. But yes, I think it's a good question whether these devices are accurate. And certainly a lot of people on the survey said that they couldn't see a pattern. It didn't, you know, there wasn't, whereas with the heart rate, they could see a bit of a pattern. And if they were in a not so healthy state, that, you know, that their heart rate was struggling and so on. And so they could use that to sort of calm themselves down and just do a lot more pacing and so on, a lot more rest. But yeah, I think it's still very much in its infancy, the use of heart rate variability. And obviously there's very little research on any of the heart rate monitors. But yes, there's a lot more needed to look at, you know, how reflective is the heart rate. And obviously with CPET tests, heart rates can be very useful, but you're right, with chronotropic intolerances for people with ME, and we don't know about long COVID, but you know, that there is, it's very difficult. And also people with POTS, you know,
Mhm.
who are really struggling because their heart rate shoots up every time they
Mhm.
move, that, you know, it's really difficult to and this is why we think perhaps other measures might be useful, like lactic acid. You know, if you've got
Mhm.
like a monitor that monitors your level of lactic acid, if we know that that's the problem for you, then, you know, that might be another way of checking. And I think also some manufacturers are exploring the use of carbon dioxide or oxygen measures on a
Mhm.
regular basis, rather than, you know, wearing a pulse oximeter. But so, yeah, I think there's other sort of physiological measures that could be picked up by watch type devices that might, you know, help people to sort of monitor themselves, not just with heart rate potentially.
Yeah, I know. I've been around a long time in this, and I know, you know, one thing we've used is to get a baseline morning heart rate over a period of time and to check that. And if it's, you know, if it's up or down, you know, and again, you know,
Mm,
a lot of
mm,
what we teach in this group is from what we've learned from Workwell, that if you
mm,
have a, you know, a significant rise in morning heart rate or a significant drop in
mm,
morning heart rate, then you probably want to, you know, take it easier that day. But it's interesting that people are using the heart rate variability to come up basically with the same conclusion.
yeah,
That
yeah,
would be interesting, I think, is to compare morning resting heart rate and the change that has happened to a person with the heart rate variability to
mm,
see if there's a correlation between the two.
mm,
Because that would be an extra, that would be like two things telling you,
mm,
you know, you really need to take it easy today. Yeah.
yeah, yeah, definitely, yeah. You had enough.
I think it's, I mean, we were very interested when you
Yeah.
presented at the conference. That's why we thought it would be
Yeah,
good to be in this group here too, also for, because it does have, like Sally said, I mean, it could be reproduced in the clinic, you know. I've, you know, I know that CPET testing in general can be controversial because there are people who do not recover, but I've never heard the reasoning that you stated first was that people say, oh, well, that's them at their maximum there, and that they're rarely at their maximum. I've never heard that as an argument before. So I thought that was interesting. But yeah, I think there's so much promise for doing something like this, either in someone's home or in a clinic or something. Yeah.
mm, mm, mm. Yeah, no, you don't probably hear these arguments because you know, it's more acceptable in ME, seems to be much better, uh much better managed, but also sort of more almost mainstream in the US. And,
Oh, you
you know,
still hear the arguments, especially in like
yeah,
chat rooms. I mean, Sally, I
mm,
don't know if you want to make a
Yeah.
comment.
Yeah.
Um,
I did the 2-day CPET, and my first ME specialist diagnosed me with permanent damage from the CPET, and I I don't agree with him. Originally I kind of bought into it, but it's a what I believe happened to me was that, first of all, I've been gaslit for 48 years. So deeply, there's not a cell in my body that does not question everything that has ever been told to me, and turn it into a character issue. Um,
mm,
so when I went in for my CPET and they told me how bad off I really was, I didn't believe them. And I thought, well, I can just cut back, like half of what I'm doing, and I can, I'll just tough it out. I've been doing this forever, and I can just, I cut back halfway. I'll be half better than I am, dragging my ass around, struggling to survive, and Stacy gave me the word. She said, if you don't stop, you're gonna die of acute organ failure. And so I began this. It took me 3 years to finally hit the bottom of where my PEM was not triggerable by cutting back on my behavior. So like I would cut back and think, oh, this is cutting back. And it would be like, nope, I'm still triggering it, and then I would cut back some more and let go of some more of my life. And nope, it's still there. Nope. It took me 3 years to finally give it all up. And that had nothing to do with the test. That had to do with everything that had been done to me, where I was told that, I was lazy, and that, this was all my fault. And sorry. And the test itself, I look back now and I know when the test quit being an issue, and it was probably about 3 weeks after, and that was it. And the rest of it was all me unlearning things that I had because of the way I'd been treated. I had beaten it into myself, and I've wondered many, many times how many people do the same thing and just don't, haven't been allowed to have the permission to grieve and to be in a place where they're supported by family and friends and economically to be able to hit the bottom, really, and to start taking care of themselves appropriately. And so anyway, I'm not necessarily a fan of CPET, because I think that there's a lot that I think there's certainly smarter ways to, and more inventive ways, like what you're doing. I think makes so much sense, because functionally it just makes a better argument to do it with what people really do in real life. I will tell you that because I had my own business, I had a private disability policy in place, because I did it to protect my business, mainly my employees, so that they could continue to get paid if something happened to me. And I always thought there would be something like cancer or get hit by a car or something like that. It never occurred to me that my ME would take me out. And I literally took my CPET and gave it to this company, and I had a 15-minute phone call with them, and then my disability was approved. And so that's how that's the power of that test. And so I think from that standpoint, it was worth everything for me, what I went through. I wouldn't have been able to take care of myself, had I not been able to access that income support and stuff. But I think that there's always better ways to do things, and I think what you're coming up with is just incredibly powerful, and has so many ramifications from that level all the way down to how a PT or physio develops a plan of care, and how it translates into GP's referral pattern to somebody else and everything. So anyway, kudos. Sorry.
Oh yeah, no, I completely. I as I say, my friend at the beginning, she has. I mean, I guess the good thing in the UK is that very rarely do you have to prove to that extent. It can be a real challenge to get the support, the funding, and it isn't a lot. But But I think the difficulty she's had is the lack of, I don't live in the same place as she does, and she's reliant on very few people, and the carers that she gets is so limited. So you're right, she's slowly gone downhill, although she wasn't in a good place to start off with, but slowly gone downhill because she's had to do most things herself. And yeah, that, I mean, I think she's found her baseline, but it is so limited. Then it's been so limited for a long time. Whereas I think if she'd had a bit more support, she might have been able to do, have a bit more of a life, to do the things that she enjoys rather than just survive.
Yeah, I think we all are on the same boat here, knowing that how not having the therapists in the medical community believe the patient, and like, Sally, you don't, you I want to hug you. I want to feel like that is exactly, your story is exactly what the next generation does not go through. And that piece of it is like what other, I mean, I know we all get this, that like, what other health condition would you have to actually like break somebody's leg to prove that it's broken? That, I mean, you can't just like push on a wound and say, yeah, does that hurt? I mean, it's just like, you just don't do that. And that's what nobody else should have to be made worse and have 3 years of recovery from something that just, was there to prove that you're sick. I don't know. I guess that's where I feel like I feel like we're almost there. We're on the cusp. It's just so frustrating that it's still happening. And that's what is, I feel like you guys at the UK and Stacey's group at Work Well, and even Paterno's lab is showing that they are on the right track, but it's, how far do we have to go to make it to the next level? And
yeah,
that's what's so heartbreaking.
I mean, for so many years, it's just been about proving that they've got a problem, when it really should have been about, let's find some solutions to this, not just proving that people have got problems. And I mean, the testing, whatever testing we can come up with, needs to not just focus on these people have got a problem. It's focusing on what can we do about it. And, as I say, I do believe that everyone's got little subsets of issues that we need to pull apart and say, okay, so they've got this will help. They've also got this will help. They've also got this. And, it's certainly from what we've found is that the more severe have more problems, which makes sense, doesn't it? So they've got dysautonomy on top of perhaps lactic acid issues, on top of, this and that and the other, whereas perhaps the mild end have just got one aspect of that. And I think, if you can be a lot more specific and individualized in testing, and then the treatment can be a lot more individualized.
And I, like Nikki, as you guys know, I participated in the Long COVID International Forum, and we had a lot of breakout sessions where we would go and discuss certain issues. And Sally's been at it for 40 years or more than 40. I've been at it for 20 years. And these people, 2.5 years, 2.5 years. And to hear them talk about the amount of gaslighting that they go through and the lack of services available, and going to practitioners who claim to know how to treat them, who have no idea, it sickens me, to know that what we've been through for so many years in such a short period of time for them is already happening again. And I really, really hope, you know, even though people are declaring the pandemic is over, you know, I really hope with the funding that they are getting for research and us, I don't mind being on their coattails at all if it'll help me, because a lot of them, I mean, if you were just to come into the room and sit down and I handed you my device and I didn't tell you what it was about, the complaints that they had, the symptoms that they had, although I know there is some difference in long COVID and MECFS, but in general, the symptoms were exactly the same as what we hear in MECFS. You know, I know there are people that have heart and lung issues and things like that, but most, I mean, in general, the post-exertional symptom exacerbation, the brain fog, you know, the dysautonomia, all that. It's just like you're listening to a group of ME patients sit around talking about the issues that they dealt with. So I'm really grateful, Nikki, for you guys doing the work that you're doing. And I'm going to be hopeful that it's going to bring around some change for a lot of patient groups.
Yeah, I mean, you know, we hadn't planned to go in to do a lot of research, but as we got more and more involved in sort of trying to educate, we realized how little research there was out there, and there were certain things that we felt we could do, as you know, we're not pure scientists, but at least, you know, we got a foot in the clinical and the foot in the, yeah. So I think we're seeing practical issues and practical problems, and you know, if we can just resolve some of the practical clinical, yeah, go beyond graded exercise therapy and and try and find some simple solutions just to help manage this a lot better. Yeah, but ultimately let's find a cure, but I that isn't what my research can do, unfortunately, but along the way hopefully we can make life a little bit easier.
Yeah. Well, there's a lot of room in between there and finding a cure. So.
Yeah, well, it certainly is. I think, you know, MS, Parkinson's, we still haven't got a cure for them, but we still treat them as physios and OTs, and we still have to find ways of improving their quality of life. And I suspect that's going to be the same for people with ME, but at least if we can improve some form of management and give them a little bit more hope than what they've had for such a long time.
Yeah.
And I think for OT and PT, I don't think in anyone's background is curing. You know, I'm not going to cure the stroke. I'm not going to cure this Down syndrome, or I'm not going to. I mean, there's no cure. It's just, what do I do with what do you have? You know, with what you have. And that's I think like what the focus always has to be for OTs and PTs is, you know, when people come to the clinic, and you know, I think that's where the psychologists in the UK got really, you know, they're so hung up on we're going to identify and we're going to cure, and it's like, that's not your job. No. You know, your job is not, a psychologist is, their job is not to cure. It's to help bring structure and organization and name it. What is it? You know, and that then people can deal with their own, you know, stuff after that. But you know, that's where I think, like, you know, OTs and PTs have to stay away from the idea that they will ever be a cure, because they're not. That's not their role. And so at least giving patients the hope of, like, you know, there isn't a magic pill, and there isn't going to be anything that's going to be right immediate, but you know, with your research and with a lot of other people's research, we at least have proof that this helps. And if you monitor, you know, down the road, if there's a tool to say, like, your lactic acid is really high, those are the tools that now you got to back off. And Sally, I'm sure that your lactic acid was out of control, and like, you just didn't know what it was. And so everybody was saying, like, well, you're crazy, but no, I'm actually being poisoned.
Yeah.
It's bringing
Mhm.
sense to what makes no sense.
I wanted to give Anne the opportunity. Anne, if you have any questions or comments and you want to put it in the chat, feel free. I'll look up, I'll monitor the chat just to see if anything comes up.
I might have to go in a few minutes, but obviously if there's more comments on the Facebook page, I can potentially keep an eye on that as well. And
Thank you for taking the time, Nikki. And
no worries. No, thanks, Anne. Thank you. Yeah, no, absolutely. And it's been lovely to meet you all in person and have a chance to chat, actually, because it's always been a bit of a in the person or at a conference. And yeah, no, it's good. It's good. It's lovely
give our
to meet you.
best to the other women.
Yeah, I think you've met Michelle, haven't you? I think she's been on a few calls. But you've probably not met Karen or Nat, actually.
No.
Yeah. We're very close to finishing our book.
Oh, that's awesome.
Yeah, so that'll be out hopefully next year. So watch this space.
Yeah, that's great. I'll see you guys.
Yeah, thanks a lot.
Yep.
Take care.
Bye.